Okay, so I'm going to go over some theories and interventions regarding the somatic disorders. So the first one we'll do is somatization disorder. There's shows to be a genetic link, so mom has it, sister has it, then increased risk that you can have it as well. The learning theorists believe that the gains perpetuates the disorder. So gains as in primary, secondary, and tertiary. Primary gains saying I get to avoid something that I don't want to do, or something that causes me anxiety. The secondary gain would be now I get attention that I normally wouldn't get, and that makes me feel happy, so I got a secondary gain. And then the tertiary gain would be, let's say mom and dad are fighting, and the daughter gets sick. Now mom and dad are focused on me, and they're not fighting anymore, and the family's happier. So that would be a tertiary gain. Okay, so the gains perpetuates the problem. Two Nandas I got out of the book for this disorder is ineffective coping. So effective coping, right, is basically deciding when something stresses you out, if it's good, if it's bad, or if it's insignificant to you. And then secondly, do you have the tools to basically deal with your stressor? But this person here still decides that they have a physical problem, even though they really don't, right? And they're so focused on their physical problems rather than really dealing with the underlying psychological issue, okay? So ineffective coping, and then deficient in knowledge. So the doctor shop, and regardless of how many doctors tell them that they don't have this problem, they feel like, yeah, they do. And so that means that they obviously don't know that their problem is really psychological. Okay, these patients don't make up these disorders for attention or like drug seeking. It's actually just the manifestation of physical symptoms due to psychological issues that they're not able to deal with. Okay, so in dealing with the patient, first of all, you want to make sure that they actually aren't sick. Okay, because you're going to feel like a jerk if the hypochondriac patient thinks he has cancer in his toe, and you tell him it's all in his head, and it ends up being he does have cancer in his toe. So you got to make sure that it actually is psychological. So check your vitals, check those labs, and okay. And then don't deny the patient the signs and symptoms. So don't tell them like, okay, it's just all in your head, because A, that's just going to piss them off, and B, that's not therapeutic, and that's not really going to gain you their trust. Okay, so don't deny them the symptoms. What you do is initially you're going to say, okay, I'm going to listen to what you have to say. Tell me about those physical symptoms that you have. And then gradually you're going to withdraw the attention away from those physical symptoms. So let's say at first you allow them to speak about it, but then you're going to limit the time in which they talk about it. Okay? So, okay, you can tell me about that cancer in your toe for 10 minutes out of the hour, and that's it. All right? So you're going to limit the time and withdraw attention away from those physical symptoms, because the real issue is psychological, right? So that's why you're going to want them to verbalize their anxieties and fears. You want to talk about what's really underlying these issues. And also, you want to identify what the gains are. Like, is this person getting a lot of attention at home because they feel these symptoms? And if they are, then that's where you're gonna deal with the issue. If the wife is giving the husband tons of attention because he's feeling really sick all the time, then she needs to stop doing that, and that will basically decrease the perpetuation of the disorder. Okay, so don't deny the patient that what they're feeling is real. Give them attention at first, then gradually withdraw the attention away from that physical symptom. You want them to talk about their anxieties and fears, because that's the real issue. Identify basically roadblocks in the way, right? Because these gains are like roadblocks. And then do things to increase their independence. Okay, these patients aren't the ones you want to baby and coddle. Okay, these patients you want them to learn independence, and doing things on their own and getting positive reinforcement from you for adaptive behavior is really going to boost that self-esteem. And the increase in self-esteem is going to decrease the likelihood of this disorder perpetuating itself, right? Okay, so you want increase in independence, increase self-esteem. Two things you definitely want to do. And then teach the patient some alternatives. Maybe they don't even know that they're doing this. So teach them some alternatives instead of feeling these physical symptoms. And teach them relaxation techniques when they feel that increase in anxiety. Don't focus so much on, I'm sure I got this cancer in my toe, but maybe some breathing techniques. Go for a run. Do something else. I mean, it takes time, but that's what you want to do. Okay, so these are nursing interventions. So we were talking about the limited time, and then let's just say you tell, the hypochondriac, okay, you can talk about your toe for 10 minutes this hour, and then they violate that, and they want to talk for 20 minutes. So what you can do is you're going to withdraw the attention away from the patient. Now, at first, they're going to be like, what the heck? They're going to feel the need even stronger. But eventually, as you increase their independence, increase their self-esteem, teach them alternatives, and teach them relaxation techniques, they're not going to feel that anxiety as much, okay? So the goal is that the patient understands what's really underneath this all. Okay, so the next one is pain disorder. Now, pain disorder shows that there's a decrease in serotonin and decrease in endorphins. The way you can remember this is we give them SSRIs or SNRIs, right? So obviously they have a decrease in serotonin. That's why maybe SSRIs or SNRIs help. And then endorphins, maybe you can remember as endorphins make you feel good. And if you don't get a lot of it, then maybe you'll feel some pain. Okay, so these are the two neurotransmitters you might see on the test. All right, the psychodynamic theorists believe that there's a guilt aspect to this. So maybe the patient feels like they did something bad in the past, or whether they really did or not, and now this is like retribution for something bad that they did. So there's a guilt factor to this. And then the learning theorist believes in the gains again, primary, secondary, tertiary. Those are the roadblocks, right? So we want to find out what those are, and we want to stop it in its track. All right, so 2 nursing diagnoses out of the book is chronic pain, that's obvious, right? And social isolation. Sometimes these patients feel like they have so much pain. And to them, it is real, right? Real enough that they need to seek medical help, right? And oftentimes, like we said, it's one or more body parts. So social isolation might be a problem as well. Okay, so the hypochondriacs, once again, there might be a genetic link. And then the psychodynamic theorists believe that these patients have poor self-esteem. So they manifest these problems in their body because it's easier to accept that maybe there's something wrong with my body rather than something wrong with myself. So they believe they have poor self-esteem, and then there's, again, that guilt aspect. I did something bad, and this is retribution for things that I've done. Okay? And the learning theorists believe that the gains again, and then they experience. So maybe these hypochondriacs actually had a bad experience or an illness, or somebody in their family had an illness, and because of that, they are now scared that that illness either might come back or will happen to them, and so that's why they seem paranoid, right? Okay, so the NANDAs for the hypochondriacs are fear of catching a disease or dying. Okay, and the fear is very real to them, and they will be very upset if you tell them it's all in their head. Anyways, no one wants to be told that shit's all in your head. Okay, so don't do that. That would be the wrong answer to select on the test. And then these patients suffer from poor self-esteem. So here, once again, you're going to want to increase their self-esteem, right? Now, conversion disorder. These are your patients usually showing neurological deficiencies after a very stressful event. Genetic tie again, psychodynamic dynamic theorists believe that. So something happened to these patients that are very stressful, and the way they feel after this event happened, they might feel like what they feel is unacceptable and immoral, and so those emotions are converted into physical symptoms. Okay, so something happens to me, and what I'm thinking about the event is I feel like I shouldn't think that. That's immoral. It's unacceptable that I think that. And now these emotions that I feel are converted into a physical symptom, like, blindness, or my right hand doesn't work, or something like that, okay? So the learning theorists believe, again, it's the gains, right? Maybe now my right hand doesn't work and I don't really have to do the laundry. That's good, right? For the primary gain for me, I like that. The secondary gain would be, my husband does everything for me and he gives me all sorts of attention and buys me nice things. That's a secondary gain. I like that too, and that perpetuates this disorder. Okay? And then they have disturbed sensory perception. Okay? And because they feel like, because the loss or alteration in physical functioning without evidence of organic pathology. So they have disturbed sensory perception. And these patients can possibly have a self-care deficit as well, right? If all of a sudden the symptoms that manifest after this very stressful event is that I'm blind or that my right or left hand doesn't work, well, I'm going to have a self-care deficit. So with these patients, you don't necessarily need, let's say like the patient is blind, you don't need to necessarily feed them or do everything for them. You can just offer them support. You know, you could bring them the tray of food and show them where it is, and then now they need to feed themselves. Okay, so you still want to increase their independence, but still show that you care. So these patients can possibly have a self-care deficit. Okay, so now for drugs. Okay, SSRIs and SNRIs are good. The book says SSRIs aren't as effective, but SNRIs are. So Effexor and Cymbalta, you know that, they're both SNRIs. Or anticonvulsants such as Dilantin, carbamazepine, or clonazepam, are both given for the somatic disorders. So remember, SNRIs, S for somatic, S for SNRIs, and then the anticonvulsants help. And then, okay, so I didn't really go over body dysmorphic disorder again, but for body dysmorphic disorder, let's say, for example, a nursing diagnosis for them would be disturbed body images, right? And let's say an outcome goal for somebody with body dysmorphic disorder would be verbalizes a realistic perception of herself or himself and expresses feelings that reflect a positive body image. So that would be something for the body dysmorphic disorder. And these patients, you can read in the book, but they often have a lot more, possibly have a lot more underlying issues, okay? So patients can be given the tricyclic antidepressants or the SSRIs, and that does work for this patient about 50% of the time. Okay, so I hope that helps.